I'm going to talk about pulmonary rehabilitation today. It came up to the forefront of my brain over the last year or two as pulmonologists and every doctor really started to see more people after a COVID infection with continuing debilitation or disability afterwards, and some of whom may be helped by pulmonary rehab, for example. So I'm just going to go through the background about the history of pulmonary rehab, what it usually looks like, the best indications for it, and then an ideal state of pulmonary rehab. And I'll kind of go into the coverage concerns and what resources are available for us locally. So I've always liked medical history, and Alvin Barrack, I think, is usually considered the founder of modern pulmonary rehab. Before his time, before the mid 20th century, people with respiratory diseases were frequently told to rest and not exert themselves, just stay in your bed, stay at home, don't stress yourself out. Dr. Barrack had a very small little cohort of people who he was able to improve their exercise capacity through a structured rehabilitation program. And Dr. Barrack is also supposedly the source of the quote, an alcoholic has been lightly defined as a man who drinks more than his own doctor. I have found that in a couple of sources, and they've attributed it to him, which I found interesting. So pulmonary rehab is, before I started pulmonary fellowship, I sort of thought it was exercise, like some kind of structured exercise program, and it's really quite a lot more than that. It's more than a Richard Simmons tape or Hans and Franz helping you out in the gym. It's a very comprehensive intervention involving exercise, education, behavioral changes. There's some essential components of pulmonary rehab that all programs across the country will do. I wouldn't call this bare bones exactly. It's still a very comprehensive program, but these are the kind of things that happen at pulmonary rehabilitation sessions based on the American Thoracic Society and things like that. So the first visit is always a center-based assessment, an intake visit, and that's usually the longest session of a pulmonary rehab course. The intake session will usually do either an exercise test or a field exercise test. A true exercise test, like a cardiopulmonary exercise testing, is rarely done. It's kind of resource intensive. But a field test is very common. That's something like a shuttle walk or a 6-minute walk test, which I'll show you examples of. A pretty thorough quality of life measure is done as well, usually the St. George's Respiratory Questionnaire or something similar. And then finally, a dyspnea assessment, a nutritional assessment, how dyspnea affects occupational status. So that tends to be a pretty long session. For those of you who don't know, this is a 6-minute walk test. It involves basically how far can you walk in 6 minutes? Usually go between two cones about 30 meters apart. And to know for later in the hospital, I'm on consult, so I keep saying hospital course day. For later in the talk, the minimally important, clinically important change in the 6-minute walk test is about 30 meters or so. So if, that's what kind of a significant difference ends up being. All right. Then the next assessment you usually get is the St. George's Respiratory Questionnaire, which is lengthy. It's about 8 to 15 minutes or so. It involves multiple domains of how are you functioning with your ADLs and IADLs, things like that. This is just a small section of it. Like what makes you feel breathless at home? The dyspnea assessment that's used in pulmonary rehabilitation and used in a lot of settings is the Borg scale, the modified Borg scale, which you can see here. And the rehab that's targeted in pulmonary rehab is usually aimed to a Borg 4 or a Borg 6, so a little intense or intense. Yeah. So once the initial assessment happens, then we talk about endurance training and resistance training. So this is the exercise prescription that is tailored to the patient and prescribed to them. So endurance training is things like a treadmill, upper limb cycloergometry. So that's like moving your arms with a stationary set of pedals. Just one sec, someone outside. Thanks. Okay, sorry about that. Some people were kind of loud outside my door. So endurance training tends to be about 3 to 5 times a week, usually about 20 to 30 minutes per session. And then, like I said, you usually try and target it to that Borg score of 4 to 6 or so. And that can usually be about 60% of your 6-minute walk distance that you've done on your intake visit. And the benefits to pulmonary rehab actually don't require a change in your PFTs or your respiratory muscle mechanics. They can happen just through development of skeletal muscle strengthening. That's been shown to reduce your respiratory rate, to reduce your required minute ventilation, to improve dynamic hyperinflation in people with COPD. So a change in PFTs is frequently not part of pulmonary rehabilitation. Resistance training is a little bit different. It usually takes a form of upper limb training, so strength training with weights for the upper limbs. This is often done in pulmonary rehab because smaller muscles, like the upper limb muscles, extract less oxygen, so people feel less dyspneic, less fatigued during doing upper limb strength training. And it's also been shown to improve 6-minute walk distance, which you wouldn't expect to see necessarily. Interval training is also sometimes used at this stage of pulmonary rehab, where this is for people who would, for example, have severe dyspnea and can't really reach a Borg of 4 to 6 because they're always at a Borg of 4 to 6. So this is helpful for inspiratory muscle training. That's what interval training ends up being. So that's sort of like the picture of what the exercise component of pulmonary rehab is. It's really important that whoever delivers this is someone who's experienced with exercise prescription, and then it's progressed at the patient's rate. You know, that the progression of the exercises is tailored to the patient. The person who does this could be a physical therapist, a respiratory therapist, or a clinical exercise physiologist. It's pretty variable, but they all should have experience in exercise prescription. And then whoever staffs your pulmonary rehab program has to be someone who is well trained. You know, physical therapists and respiratory therapists usually do get training in this, but you, for example, wouldn't want to pull off a inpatient focused respiratory therapist to all of a sudden staff your pulmonary rehab center without more retraining. So this cogwheel is the essential core components of pulmonary rehab. And now we kind of have an idea of what the essential components of pulmonary rehab are. I will kind of talk a little bit about how it's beneficial for patients, the indications for it, and the evidence that underlies why we can prescribe it. The evidence is a little difficult. Mortality is a big outcome, of course, for people with respiratory disease, but it's not studied very frequently in pulmonary rehab. And in a Cochrane review of mortality, it's not very strong that there's a benefit to pulmonary rehabilitation for mortality. All of these subsequent slides are going to be focused on people with COPD, which is the disease that has the strongest evidence for pulmonary rehabilitation. But we'll talk about some other diseases as well that pulmonary rehab can be helpful for. None of these studies used mortality really as a primary outcome, so it can be more difficult to draw conclusions about this. When the ATS, the American Thoracic Society, or similar respiratory organizations like the American Lung Association advocate for increased pulmonary rehabilitation coverage and access, they often point to this paper, which was a retrospective cohort study. It's using Medicare claims data, and it's looking at whether or not you got pulmonary rehab within 90 days of an acute exacerbation of COPD admission. Those that did show significantly less one-year mortality compared to those who didn't, or after 90 days. But again, this is about the strength of the evidence for mortality that pulmonary rehab has. It's a retrospective Medicare claims data study. Beyond mortality, though, there's certainly plenty of things that our patients with COPD or other respiratory diseases would value. Exercise capacity being a huge component of that. And I think this is one of the strongest evidence bases for pulmonary rehabilitation. So this cluster of randomized trials of pulmonary rehab showed an average 6-minute walk distance improvement of about 62 meters, which is pretty good. The minimum important difference that I mentioned earlier is about 30 meters. So these are people who really did have a significant increase, both statistically and clinically, in their exercise capacity. Pulmonary rehab has also been shown to improve people's healthcare-related quality of life. This is through the St. George's Respiratory Questionnaire. So all of these studies showing a trend towards improvement with pulmonary rehabilitation in their quality of life assessments. So the vast majority of studies in pulmonary rehab focus on people with COPD, and it's shaken out to create some guideline recommendations, one of which have then been translated into Medicare reimbursement. So people with COPD, which either have an airflow severity of gold 2 through 4, so that's a FEV1% predicted less than 80%, for example. Those people have basically a diagnosis that would support payment for reimbursement for pulmonary rehabilitation. That severity of COPD is what has been most studied in the previous literature that I went through. Beyond the airflow limitation, though, people who have severe symptoms of COPD as well can qualify for pulmonary rehab prescriptions. Gold B through D, so B, C, and D. These are people who have frequent hospital admissions or severe symptoms, high symptom scores, and frequent admissions over the course of the year. So what I've presented so far, I think, gives a pretty limited view of pulmonary rehab. And that's just a function of both the literature that supports pulmonary rehab and also the payment environment, I think, of pulmonary rehab. I've sort of described that COPD of this severity is the indication for it. And the essential components of pulmonary rehab that I showed a little earlier are all tailored to people with COPD. But I think pulmonary rehab can be so much more than that. And that's the focus of current research and current development in this area. So some extra components of pulmonary rehab in the assessment arena might include like an anxiety and depression assessment. It's pretty well documented that people with COPD have more depression, more anxiety. They have complicated inhaler regimens and extra teaching surrounding inhaler usage, nebulizer usage would be very important. And then there's so many comorbidities that affect people's respiratory health, obesity, diabetes, all sorts of things. And a kind of a thorough and individualized assessment of patients' comorbidities is a good part of pulmonary rehab, sort of like an idealized component that you would add to the assessment if you could. The program components themselves, Georgetown, of course, is very well known through Dr. O'Donnell for its bronchiectasis program, and airway clearance is a very complicated for the patient and for the provider therapy that's used for bronchiectasis, cystic fibrosis, and teaching airway clearance techniques and reinforcing that over the course of a multi-visit pulmonary rehabilitation program, I think would be very helpful. And some pulmonary rehabilitation programs will do this as well. This can be things like teaching people how to use a cappella valve, a positive expiratory valve, which can help loosen and break up secretions, teach people how to use a percussive vest, how to do, or teach a loved one how to do home physical therapy for chest PT, chest percussion, how to use your nebulizer correctly, all sorts of things. Smoking cessation, there's certainly a large association with smoking and COPD, and a structured program like pulmonary rehabilitation with multiple sessions over the course of several months. That's a great opportunity to introduce smoking cessation, to prescribe, for example, nicotine replacement therapy or pharmacologic smoking cessation tool, and then tracking progress over time and offering changes or encouragement to the patient as they go through that. Respiratory diseases are complicated. Beyond techniques like airway clearance and inhaler teaching, just a basic education about COPD, bronchiectasis, whatever the respiratory disease might be, would be a helpful component to this. Particularly for anyone with a respiratory disease, but particularly people with, for example, COPD and asthma might benefit from kind of a fine tuning of their exacerbation action plan. In other words, perhaps it's set in a physician visit, but then tailored over the course of this pulmonary rehabilitation visit. In addition to pharmacologic exacerbation management, I'll describe some breathlessness breathing techniques and things like that that can be part of a very comprehensive pulmonary rehabilitation program. And finally, pulmonary rehabilitation ends at some point. The structured program does end based on the, what's covered by payers, for example. So having a home exercise plan that can reduce sort of backsliding, reduce recrudescence of their symptoms can be very helpful. This is usually something like a maintenance exercise program that the patient can do at home or at a gym or just around their neighborhood by walking. And then finally, the delivery of pulmonary rehab. The existing paradigm of it being a physical location that a patient has to go to several times a week is I think pretty outdated and very challenging for for patients to achieve. So different models of pulmonary rehabilitation delivery are in the launching pad of for different research studies and delivery models and ensuring that those are effective. And then finally, pulmonary rehabilitation, I think, can be a little bit better tailored to people's comorbidities, such as musculoskeletal comorbidities like osteoarthritis, or cognitive comorbidities such as dementia. And then lastly, we've discussed the limitations of evidence that exists for pulmonary rehabilitation outside of the realm of COPD, and really registry participation, quality assurance of the individual programs really needs to be ongoing, and a robust research portfolio should be established for this area. So these extra components of pulmonary rehab that I described, they, I think, would all help people with COPD, but they also open up pulmonary rehabilitation to be more effective, more useful for patients who have other pulmonary conditions. Each of these has some literature base to support the use of pulmonary rehab, but it's not as robust as COPD, and that's evidenced by the payer environment for this. Interstitial lung diseases, this is a very heterogeneous group of people, but pulmonary rehab has been able to improve their exercise capacity, improve their healthcare related quality of life as well. Bronchiectasis, exercise capacity has been demonstrated to increase. Inspiratory muscle strength has been demonstrated to increase as well. And you can see how some extra components of pulmonary rehab, like airway clearance therapy, might be more helpful for people with bronchiectasis. Same thing with cystic fibrosis, better exercise capacity, better health-related quality of life. Asthma, really only health-related quality of life has been shown to be an improvement here. I think that's probably related to usually the episodic nature of asthma compared to COPD. Pulmonary artery hypertension is a tricky condition, but and traditionally it wasn't pulmonary rehab wasn't well researched for people with PAH. And the reason for that is that there's concerns that people with PH could have, concerns that people with pulmonary hypertension could have palpitations with exercise, syncope with exercise, and sudden cardiac death with exercise, for example. But more recent research has really shown an improvement in 6-minute walk distance with pulmonary rehabilitation, but these studies are actually all of submaximal exercise, so a lower exercise prescription than what other people with other respiratory conditions would have. Lung transplant, both pre-transplant and post-transplant, have been shown to improve transplant outcomes through the improvement in exercise capacity, and some transplant programs mandate pre-transplant pulmonary rehabilitation before someone will be listed. So those are a pretty long list of other respiratory diseases that pulmonary rehab might be beneficial for. One of the big ones that, of course, has come up in the last 2 years is the PostCovid syndrome. So this is another area where the research environment for this is new. And what's been published on pulmonary rehabilitation and post-COVID syndrome is early, and the studies tend to be retrospective cohort studies, for example. This is a retrospective cohort study looking at the 6-minute walk distance of people who were in the ICU, but in the ICU with COVID versus in the ICU with another condition, a non-COVID condition. The blue boxes here are people with a non-COVID ICU admission, and the red boxes are people with a COVID ICU admission. Both groups showed an improvement in 6-minute walk distance, with the post-COVID group showing a slightly higher improvement in 6-minute walk distance after this. Same thing with other functional assessments and health-related quality of life. Those have also been shown in some cohort studies to be improved in people with COVID post-ICU. But not everyone with post-COVID syndrome has been in an ICU. I've seen pretty debilitating post-COVID syndrome from people who are not hospitalized or hospitalized on an acute care floor, for example. This is from a German study, and it's difficult to apply this to the United States because this is involving a 3-week inpatient pulmonary rehabilitation program. Still, though, what this is showing is that this is measuring fatigue levels in different groups. We've got T1 here is before the pulmonary rehab program. T2 is after the pulmonary rehab program. Group A are people who had very severe COVID symptoms, and they were hospitalized, and they were admitted directly to the pulmonary rehabilitation center from the acute care hospitalization or within one month of that. Group B are people who were hospitalized but didn't have and could have had as severe symptoms as Group A, but they were sent to a pulmonary rehabilitation facility greater than 1 month after their discharge from the hospital. So this is kind of like a delayed pulmonary rehab. And then Group C are people who had more mild COVID symptoms, and they were treated as an outpatient, so not hospitalized, and they could have been sent to pulmonary rehab at any point. The different shading shows you the level of fatigue that people had, and you can see in every group there's an improvement in fatigue score. So less people report moderate or severe fatigue. More people have fallen into this mild or no fatigue section. This is sort of the extent of a lot of post-COVID pulmonary rehab literature, but I'll talk a little bit more about that when I talk about payers, that this has entered into as a covered diagnosis code for pulmonary rehab now in the United States. So if anyone has had experience prescribing pulmonary rehab and referring people to a pulmonary rehabilitation program, I think you've probably encountered problems with access, uptake, and completion. There's a fairly robust research group that's looking at why isn't pulmonary rehabilitation used as frequently, and what are the limitations to having patients do it. To define this a little bit, access is referring to the geographic presence of programs, and if the program is present, are eligible patients referred to it. This is an example might be rural parts of the country that have no geographic presence of pulmonary rehabilitation, or people who are in well-covered parts of the country, but are just not referred by their physician or advanced practice provider to pulmonary rehab. So that's access. Regarding access, this is what has been studied about this, is that really small number of people who have COPD even have access to pulmonary rehabilitation, less than 4%. So these are people who don't have geographic presence of a pulmonary rehabilitation program. Even if they are referred to a pulmonary rehabilitation program, only less than 2% of people actually attend that program within 6 months of their referral. So that's the first visit, basically. So this is meaning that a small fraction of people have a geographic access to pulmonary rehabilitation, and only a small number of people who have that access actually go to it. Uptake is whether they show up. So that's kind of what's talking about this last bullet point here. Even people who get a referral to pulmonary rehabilitation, uptake is very low. About a third of people who actually get a referral don't show up to the first pulmonary rehabilitation session. And then completion is the concept of they go to the first session, but do they finish out the entire program? And that also is fairly low. Usually about, oh, sorry, that's a little bit higher. So usually if you go to the first session, 2/3 roughly of people will complete the program. Things like current smoking, frequent hospital admissions, a shorter baseline 6-minute walk distance, so less exercise capacity at baseline, and a longer transportation journey to the pulmonary rehabilitation center are all huge factors in completion and uptake for people. A lot of pulmonary rehabs won't admit people who, for example, have a heavy tobacco scent on their clothing. If you have COPD and frequent exacerbations, you're going to miss a ton of sessions. If you have a shorter baseline exercise capacity, it's much harder for you to leave the house, for example. And then transportation is a huge problem with this, both how far away are the patients? How accessible is it by public transportation or a metro access sort of thing? Is there a family member or friend who can drive them? What is their schedule like? It's very difficult. Still, despite all these limitations to pulmonary rehabilitation, at least in the United Kingdom, it's been shown to be pretty cost-effective therapy for COPD, really kind of lying in between a tiotropium, like a LAMA therapy, a long-acting muscarinic antagonist, and between smoking cessation. So it's a pretty sizable chunk of the base of the pyramid for people with chronic obstructive pulmonary disease. Again, these are UK numbers. This is a little difficult to translate here. Okay, so I'm going to pivot a little bit to coverage, payer coverage for this, which is a challenging area for pulmonary rehabilitation. So traditionally, this is the payment scheme for the reimbursement scheme for pulmonary rehab. You can see the pretty significant difference between COPD, which is strike through on the fourth line here, versus cardiac rehab. The parity was not there at all historically. And if you didn't have COPD, you could get pulmonary rehab based on the geographic Medicare provider. So it was sort of a patchwork coverage across the country, and it reimbursed at this extremely low rate. So this is general pulmonary rehab. This would be for any other indication. However, in the last 2 years, with the advent of the COVID public health emergency, that's actually allowed for virtual pulmonary rehab to start. That has it hasn't been well studied if this has actually improved access, uptake, and completion for people, but at least it seems to be more available. They also did away with this COPD specific pulmonary rehab CPT code G0424 and have replaced it with two codes, one of which is for pulmonary rehab with continuous pulse oximetry, one without. And that change, which happened actually just this year, so January 2022, these CPT changes happened. And it has improved the parity to where now pulmonary rehab for those two specific indications of COPD and post-COVID are on par with cardiac rehab. So it's only been a couple months. I'm not sure how that's translated into access, uptake, and completion for our patients with COPD. Then the other new thing that happened, of course, in the last 2 years is that PostCovid Syndrome diagnosis code has been allowed as a covered diagnosis for these two CPT codes. So I think the stage is set for better pulmonary rehab reimbursement and better pulmonary rehabilitation coverage for our patients. There's a lot of new directions for pulmonary rehabilitation programs because even if it's covered better, it's still there's still a lot of access, uptake, and completion issues related to transportation, to smoking, to low baseline 6-minute walk distance, just to name a couple. Some new directions that are being examined for this are home pulmonary rehab. So a exercise physiologist, physical therapist, respiratory therapist goes to the home and provides pulmonary rehabilitation sessions there. Another possibility is tele-PR, which has come into the forefront in the last 2 years during the COVID public health emergency. And I believe the coverage for tele-PR is still in place until September of 2022, I believe. So this can involve like a one-on-one tele session with a patient, or it could involve a sort of a group class, like this Zoom talk, for example. Web-based self-paced pulmonary rehab. Another good MedStar example for that would be our Cytel modules. So this is something where like you log in, it's a structured program, you just go through it at your own pace. Community pulmonary rehab has usually been studied in places that don't have geographic access to pulmonary rehab, so more rural settings, for example. And this is usually a group pulmonary rehabilitation sessions that are held at non-healthcare settings, so a gym or an outdoor track or a YMCA, something like that. PCP, pulmonary rehab, has been studied in the United Kingdom and involves essentially hosting pulmonary rehabilitation sessions in a primary care clinic. And usually this is also in a rural or resource poor environment where the primary care practice in the United Kingdom might provide a lot more than pulmonary rehab and primary care. They might have, for example, dentists there and stuff. And, it serves as like a hub of healthcare for the community. Minimal equipment pulmonary rehab is used similar to community pulmonary rehab a little bit, where you'd use things around the environment. And this is particularly helpful for low and middle income countries trying to establish a pulmonary rehabilitation programs. It might include endurance exercises that don't require a treadmill, don't require a cycle ergometer, for example. And so no specialized equipment, not in a gym or anything like that. And then finally, breathlessness pulmonary rehab is more symptom-based and really maximizing non-exercise techniques for improving dyspnea and quality of life. Those can look like this a little bit. So the person sitting in the chair on the left is doing what would be taught in breathlessness pulmonary rehab, for obstructive lung disease. So sitting forward with arms supported, and what this does is it increases muscle activity of the inspiratory accessory muscles like the scalene and the pectoralis major, the sternocleidomastoids. And it also, by hunching forward and compressing your abdomen, you're increasing your intra-abdominal pressure, which can help with dynamic hyperinflation that happens with COPD as well. So that can improve the sensation of dyspnea. The person on the right is sitting upright in the chair, back against the back of the chair. And this is thought to be a better position for people with a restrictive lung disease because it improves diaphragmatic contraction compared to the slouched position for obstructive lung disease here. Okay, so I put this slide up here to go through very quickly. Looks like we still have a couple minutes left. So to go through a deep breathing exercise that I think could benefit both our pulmonary disease patients and also probably just all of us. I find it kind of helpful and therapeutic to myself as well. So everyone just, you can stare at the screen or close your eyes, but here's what you do. So put one hand on your chest, put the other hand on your stomach, close your eyes or look at this beautiful beach scene here. Slowly breathe in through your nose with your mouth closed. If you're relaxed, what you want to feel is that the air will reach low into your lungs and your stomach will move out against your hand with your hand on your chest barely moving. So breathe in through your nose with a closed mouth. Feel your stomach moving out against your hand, but your chest barely moving at all. And then breathe out through the nose and feel your stomach fall gently. Imagine all the tension leaving as you let the air out. This is a pretty common deep breathing exercise that's taught to anybody with dyspnea, regardless of the etiology. And I find it kind of helpful too. Another breathing exercise that breathlessness pulmonary rehab might be helpful for is pursed lip breathing. I found that people, I think, discover this on their own a little bit. People with a COPD, especially an air trapping disease like COPD or asthma. The pursed lipped breathing technique improves your extrinsic PEEP, so your extrinsic positive and expiratory pressure, and that can reduce your dynamic hyperinflation, so the air trapping that's occurred in your lungs. If you reduce your dynamic hyperinflation, that when you have a lot of dynamic hyperinflation, your diaphragm flattens out, which is not a very productive position for your diaphragm to be in for breathing. So reducing dynamic hyperinflation improves diaphragmatic flattening, gives it back its nice cone shape, and can improve dyspnea. All right, so the last couple minutes, I'll just talk about local resources. Dr. Welton, before everyone came on, mentioned that he has to send his patients to Holy Cross. Well, so do we. Baltimore resources, there's a couple non-MedStar, but Franklin Square has a pulmonary rehab place. But in the DC area, we're in a little bit of a desert here. Shady Grove Adventist and MedStar St. Mary's are really some of the closest places. Innova's website says that they have a couple places in Northern Virginia, but I'm not 100% sure which of these are open or not. And prior experience with referrals there, I've usually had a long wait list, for example. So I think your mileage may vary if you have a Northern Virginia patient. MedStar offers something called the MedFit program, which is just a pay out of pocket structured exercise program, and it doesn't include the more comprehensive assessment and exercise prescription that pulmonary rehabilitation should offer. So this is sort of like a substitute, for example. I need to mention Grace Ann Dorney and her husband Ted Koppel, who Grace Ann Dorney was diagnosed with COPD, I think about maybe as far as 20 years ago, and had pretty debilitating symptoms from it. She went through a pulmonary rehabilitation program and found it so helpful in improving her quality of life and her exercise capacity that she funded a foundation to support pulmonary rehabilitation centers around the country in more, or actually it's more mid-Atlantic focused, but to support programs like that in underserved communities. So MedStar was the beneficiary of a grant from them, and that helped them to open the Grace Ann Dorney Pulmonary and Cardiac Rehab Center at St. Mary's. And then finally, the American Lung Association, and I think the COPD Foundation offer free peer support groups. This one is called the Better Breathers Club, offered through the American Lung Association, which are really just a support group for people with chronic respiratory disease. And that can provide some improvement in how to manage dyspnea, how to manage your symptoms, things like that.